Okay, I'm going to tape. I got to do this at some point today or tomorrow. So when the people are here tomorrow, I think I'd rather do it today. Talking about fetal monitoring. So when we talk about fetal monitoring, today we're going to cover the contractions, we're going to cover the decelerations, the type of decels, and we're going to talk about fetal well-being. When we're monitoring fetal well-being, what do y'all think that means? Fetal well-being. How well is this baby, right? How can we see that? On a strip, right? On the monitors. So we're going to be looking at fetal well-being. There's different things that comprise fetal well-being. The fetal heart rate, we're talking about baseline. We're talking about accelerations, decelerations, and variability. How fluctuating is this heart rate? We can do it intermittently with a Doppler. The Doppler is similar to your cardiac patients' Dopplers that you'll listen to their pulses with. We're looking for fetal heart rate. So we'll put it on mom's abdomen. It sounds a little different than the big monitor. And we can find fetal heart rate with a Doppler from 10 weeks gestation on. You may not find it with the big monitors for at least, you can probably hear it around 16, 17 weeks. But the baby is so tiny and flipping all over the place, you can't keep it on a monitor to even trace it. So a lot of time we'll do a Doppler. And if the patient goes in to see the doctor, for their visits, after 10 weeks on, we do a Doppler to document fetal heart rate. Continuous monitoring, well, that would be being on the big monitor. Or we could be intermittent monitoring on the big monitor as well. Sometimes we get those patients that come in with a birth plan. They don't want continuous monitoring. They want intermittent. So we can leave them on the fetal monitor 45 minutes and then take them off for 15 minutes, 30 minutes, whatever the birth plan says. Again, getting physicians okay and making sure it's safe and we can accommodate that. We have enough nurses on duty and things like that. That is something that you need to think about because it's all part of, taking care of mom and baby. When we talk about internal monitoring, we're talking about two different types of monitors, and I'm going to bring those next week because I didn't get a chance to bring them to class today. But those are the internal monitors that I kind of touched on, I think it was last class. That's the fetal scalp electrode to trace the baby's heart rate. That's the one the nurses can put on. A nurse, a doctor, a nurse practitioner, somebody can put that on, okay? Doesn't have to be solely an MD. Big thing with that, we learned about suture lines last week, and the fontanelles, and the soft spots, and places where, you're feeling around. You don't want to place it on a fontanelle. It's a little like ballpoint, the little ballpoint pens, how they have the little spring in there. It almost looks like that on the end. So what you're doing is you're pushing it up against the baby's scalp and you kind of twist it. So it's like a corkscrew and it goes in the baby's scalp. Again, we don't really do this. This is kind of like heroic measures. If a baby's continuously not staying on the monitor, but we can auditorily hear a drop in the heart rate and we want to know what's going on. Baby's high risk, so we may want to put this on just to make sure that we can trace this baby accurately. We can also put on the monitor for the contractions in the internal mode, and that would be your intrauterine pressure catheter. And the trade name for that is koala. It sounds like koala bear, but it's a koala. And the doctor may ask you, nurse, can you hand me a koala? I want to put an internal monitor in this patient. That would be somebody that we're running high-dose Pitocin on them, and we want to get an accurate contraction pattern. The only way to get an accurate contraction pattern is with a koala or an internal uterine pressure catheter. Or, what's the other way, y'all? The most accurate way to monitor the strength of the contraction. Y'all have two of them. Palpation. Y'all remember that name? That term? You're going to touch mom's belly. You're going to assess. You're going to feel the contraction build. It's going to get harder and harder and harder, and it's going to get the hardest. And then it's going to come back down. It kind of is, and there is a screen in this PowerPoint that talks about it. Usually starts off feeling like the nose at resting tone. Then it gets as hard as the chin. It's not hard, but it's hardening. And then it gets as hard at the acme or the peak of the contraction. It's like your forehead. It's the hardest. Then it goes back down to this and down to resting tone. And it makes like a bell curve. So on the internal monitors, we can also pick up accelerations. God bless you. Decelerations and variability. What's variability? That's the fluctuating and how much it's fluctuating, the baby's heart rate on the monitor. We want it to be variable. Variability, it varies, right? So we don't get that confused with the decels we're going to talk about in a little bit. But variability is how fluctuating or how active is the heart tones, or are they up and down? When they're flat or minimal, baby's either in a sleep cycle or mom has some kind of narcotic going on that's affected the baby, that is making this baby sleepy. Or it could be that this baby's not getting a lot of oxygen for one reason or another, and at some point in time we might see some decels start up because that baby is flat on the monitor. It's telling us, you ever go into a stuffy room in a crowd and you see people passing out because they're not getting that oxygen? It's kind of like that. Baby's not getting oxygen, so it kind of, you can see it's not getting the oxygen because it's flat. When we're picking up fetal heart rate on mom, remember we talked about where you can hear it the most, or the most prevalent. Where is that? Over what part of the baby? The baby's back or spine. That's why when we do Leopold's, we're feeling before we put monitor pieces on mom's belly to see where this baby's lying. Where I'm going to put that monitor piece is where I'm feeling that the baby's got its back, because that's where I'm going to auscultate it the best. So if I'm drawing that imaginary line over my umbilicus, dividing my abdomen in a top half and a lower half, if I'm finding fetal heart rate above that imaginary line, chances are the baby's breech. The baby's head and the chest and the back is all up. So I'm going to be tracing heart rate above that imaginary line of that umbilicus is my landmark. If I'm picking them up on the bottom half, my baby's probably vertex or head down. But I can even say what position that head is being vertex. If it's OA, remember that's the most ideal way for this baby to be delivered. The baby's looking at the ground coming down. The back of the head is what's slipping under that pubic bone, and it slides right under because it's smooth. Okay? If the baby's OP, sunny side up, is looking up, it's harder to pass those facial features under that pubic bone. It's a little bit difficult. And these patients usually have a lot of back labor, and it's a harder time for them. They do a lot more pushing. It's a lot more strenuous on mom. So when it's OP, sunny side up, we can even pinpoint if we're getting heart rate, heart tones, almost to mom's rib cage or her side, it's probably OP. The closer to the midline, it's OA. And when we look at this and we document what position, if it's ROA or LOA or LOP or ROP, remember the occiput is the landmark. And if that's mom's right side, even though it looks like when we look at the patient, we want to say that's the left, but that's mom's right. So when you document, you almost have to say, okay, if I'm the patient laying there, this is my right. So the occiput anterior, and it's to the right or the left, whatever it is. But that's how you can find also after you do this, that slide should be before the other one. But you're feeling for Leopold's because you're feeling for those body parts. You want to feel. So I'm not only tracing it up here saying, okay, well, that must be a breech because baby's got a butt down here and a head. So where I'm feeling that head on the bottom, if it's breech, sometimes that head is right under mom's diaphragm. So that baby is definitely breech. If I'm feeling a head up there, and then I'm finding heart tones above that imaginary line, it all kind of goes together. We have a breech presentation. And again, Leopold's is something you'll see the nurses do. They're just feeling. They're feeling around. When we talk about monitoring, we talk about maternal well-being, not just baby or fetal well-being, but maternal well-being. How well is she coping with this labor? Sometimes they're not coping very well, especially if it's first-time baby. They don't know what to expect. They're almost just scared to death. So the coping already is compromised because they're fearful. Support. Is there support there to help her? Is there a labor coach or is there a significant other? And if it's a teen, I mean, we have 13, 15, 16-year-olds. We had an 18-year-old. It was her third baby one day. And even though it was her third baby, she was scared to death. And there was nobody with her. Okay, so again, the support system. You need that support system. It helps. And if there is nobody, then as the nurse taking care of that patient, that's why we only get 1 or 2 patients on those units. Because the acuity can be high, especially if you got somebody that, don't leave my room, please, don't leave me. I'm hurting. Can you just wait till this pain goes away if you got to leave? Or as soon as I get some pain relief, if they want to put that needle in my back, which I'm scared to death, again, fearful. Very, very fearful. So as a nurse, we're going to be their support person. We're also going to make them knowledgeable or assess their level of knowledge. So if they are just a first-time patient having a baby, or they're very young and it could be their third baby and they don't remember when the first one, they were like a child themselves. So again, assess the knowledge level. And the students will say, it's a third baby, she's 24 years old, she knows. Well, they're all different. Every labor experience is different. I can vouch for that. My son was completely different from my daughter. And I was older, not old, but older. And I'm like, yeah, I'm an L&D nurse, I know this and that. And I'm like, oh, Lord. I didn't realize that I was walking around and I was 6 centimeters. I had a little bit of cramping going on. I went for my doctor visit and she's like, you're 6 to 7 centimeters. I think we're going to have a baby today. So again, I'm like, really, are we? Okay, well, I'm not really ready. It doesn't really matter. You better get ready because you can have a baby in probably about 4 hours. So again, but they're all different. I didn't have any of that with my daughter. Again, first-time babies, they take forever. So they're all different. I was also preeclampsia. I had preeclampsia with my daughter, and I didn't have that with my son. I had preterm labor with my son. They're all different. They're all different. So you want to assess the knowledge. Physical comfort. And going with knowledge, a lot of times hospitals will give them those prenatal classes, because we'll have moms come in the first time. They're like, I don't even know how to put a diaper on. I don't know anything about feeding a baby. I don't know anything about breastfeeding. But they offer these classes, and they're usually free if they're going to deliver at that facility. So, give them some knowledge. We tell them about signing up for the classes, and they give them pamphlets about it when they go for their little visits at the doctor's office. Physical comfort, positioning, and supine hypotension. Well, of course, we know laying flat on the back is not a good position for mom. It sets her up for supine hypotension. So we always positioning them from left to right side, or, just kind of giving them a lot of pillows and a lot of support on their back. Another thing I wanted to say with supine hypertension being on their back, they tend to lay flat on their back a lot. It just, especially if they have an epidural, their legs are very heavy and they just kind of they can't really move themselves around. But as the nurse, you're repositioning your patient, whether she has an epidural or not. I'm going in and out of those rooms. I want to make sure that she's on her left side, and then maybe turn to your right side, and then maybe back on your left side. Because, especially with the epidural, think of a bottle of water, and you turn the bottle this way, all the fluid goes to that side. Well, that's what happens with the epidural. It works by gravity, okay? So if you lay on your right side, this whole side is going to be completely numb. I've had patients moving their leg around. They're like, I can move the left side, but the right side is completely numb. So just to avoid it or to completely keep them evenly distributed with anesthesia, we're going to flip them from side to side. And it's usually every hour I'll go in the room and I'll say, why don't we turn on over this side before that side wakes up? You know, we want to keep you comfortably all around. Supine hypertension, again, we just don't want them on their back, whether they have an epidural or not. Okay, monitoring contraction patterns. Well, palpation is the most accurate way other than the koala or the internal uterine pressure catheter, the IUPC. The external monitor is a way to monitor, but it gives us an idea or a ballpark figure of how these contractions are. And we express that when we document it as mild, moderate, or strong. If you have an IUPC monitor in, we measure that in millimeters of mercury. And they'll have millimeters of mercury written on the strip. And wherever the peak is or the highest part of the contraction is, it's hitting 50 millimeters of mercury, whatever it might be. Those are the most accurate ways to monitor: palpation and the IUPC, or intrauterine pressure catheter. Everything else is just an idea. When we talk about frequency, that's the time period from the beginning of one contraction to the beginning of the next. And that's how we document it. So until mom is in a really good labor pattern where they almost look uniform, they're almost all the same distance apart from one another, sometimes it takes a while to get there, to build up that good pattern. But when we document, we're counting from the beginning of one to the beginning of the other for frequency. Now, 1 and 2 might be back to back, but 2 and 3 might be a little further distance apart. So when you're monitoring when you're documenting until they're in a really good pattern, and you can say they're every 2 to 2 minutes or every 3 minutes, you may have a range until they kind of pick up that pattern and they get in the groove, right? So it could be every 2 to 4 minutes in frequency. Same with duration, from the beginning to the end of that contraction. When it leaves that resting tone or that baseline, usually it's 10 millimeters of mercury. We just look at 10 millimeters of mercury, even though it's an external monitor. But when it leaves and then it comes back down, we count those little squares. Those are 10-second squares. So it could be 50 seconds. Then the one behind that could be 40 seconds. And then the one behind that could be 70 seconds, lasting longer than the other two. So when we document, we can say it's between 40 to 70 seconds in duration. So again, it might be in a range and not so much. They're lasting 60 seconds each.
How many contractions do you
20 minutes. We're looking at 20 minutes of a strip. Every time you evaluate that strip and you walk in that room, if I walk in that room, I'm going to get my vital signs. I may increase my Pitocin if she's being induced or augmented on Pitocin. And even if I'm not running Pitocin, I'm in that room every 30 minutes. As long as that mom is on a monitor, I'm checking her vital signs. I'm checking her heart rate on her baby. I'm checking the contractions. Usually, like if someone's running Pitocin, the doctor's order will say increase by so many milliunits per minute until there's 5 contractions in a 10-minute period. So if I'm looking at a 20-minute strip, I want to see 10 contractions. And then, of course, you got to make sure, again, it's not just seeing the 10 contractions because they could be irregular. So you may continue to run that Pitocin until they're also more uniform and regular, because the doctor will say that. A lot of your orders, and someone asked me this before, how do you know that you can put oxygen on patients and things like that and do what you do? Turn the medicines off and stuff. A lot of your OB orders are pre-typed or written, and they're on the chart, and the doctor kind of checks off the boxes and says, this is what I want you to do. Okay? you're covered with those orders. You take them off. Now, of course, if there's something going on that you can't follow through with one of the orders, you question it or you call the physician. But ideally, when we evaluate a strip, we're looking at 20 minutes of a strip. You can't just look at 5 minutes of a strip and say, okay, I need to increase the Pitocin. It's not happening. The contractions are not happening enough. You're looking at a 20-minute cycle. So we covered frequency. We covered duration. We talked about external monitoring with palpation. That's the most accurate, or the IUPC, with an internal monitor, intrauterine pressure catheter. When we talk about contractions, they are the primary force. Remember last week we talked about the powers? That was the patient pushing and the contractions themselves. When we work together, it usually is the most, beneficial for the patient with labor pain. So the primary force being the contractions, the purpose of the contraction is to forcefully squeeze or contract to push this baby down that birth canal and get that baby where it needs to be in that pelvis and get it to come back down to deliver. So that's the reason for the contraction. One big thing you want to note, especially if you're running Pitocin, and remember, I don't know if I had said this last class or the class before, we talked about giving terbutaline to space contractions out on a patient that may not be in preterm labor, but we're going to give terbutaline to space out the contractions. Mom comes in, boom, she's contracting one right after the other. We want at least 60 seconds in between those contractions, because it's just like if I took a pillow and I put it over your face for how many seconds the contractions occur, and then I pulled it off. And I don't give you a whole lot of time to recuperate, and I'm putting that pillow back over your face again. Because remember, with those contractions, it's causing some transient hypoxia to the baby. And usually a healthy baby can withstand that. But even the healthy baby, if you're having contractions one right after the other and there's not enough resting tone in between, this kid is going to poop out on you. Okay? So you got to have at least 60 seconds. The pattern of contractions, well, we talked about resting tone, frequency, duration, and the intensity or the strength. With an external monitor, remember, that is just an idea. It's not the most accurate. But again, it gives us an idea. Contractions are painful because of hypoxia of compressed muscle cells and the nerves, the nerve ganglia in the lower uterine segment. We'll have cervical stretching and as well as stretching of the perineum. So all this is all going on to get this baby to come down. It can be very, very painful. Monitoring contraction patterns. When we talk about uterine contractions, the pattern, we break down the contraction into parts. The contraction just doesn't come and leave. It builds up. It looks like a bell curve. So it starts out here as this is like my baseline, and then it starts to build. This is the increment phase of the contraction. The peak or the acme is the peak or the highest point of the contraction. And then the decrement is when it's declining. Think decrement, D-E-C, I think of declining. And then it's back down to baseline. And when we said we want at least 60 seconds in resting tone, here's where my resting tone would be on with these two contractions. Because I could have it right coming up again. If it's not enough time, it's going to cause some possible fetal hypoxia that's going to affect the baby's well-being. So my duration, again, is the beginning to the end of the contraction. Frequency is the beginning to the beginning of the next one. And then when we talk about the strength, if I'm talking IUPC, as soon as I look at documentation and a nurse is documenting strength in millimeters of mercury, that tells me right there this is an internal monitor. The only way you can document an external monitor is the most common way you see your patients being monitored is with strong, moderate, mild, or you can say upon palpation, strong, mild, whatever. People that we're running high-dose Pitocin on, that we want an accurate labor pattern are going to have an IUPC. A fetal scalp electrode. I can hear a decel on the monitor, but it's kind of broken up, and I can't really trace it on the strip. So if I'm going to be doing stuff, and I really want to know what's going on with this baby, I want an accurate pattern. I can put the fetal scalp electrode. If it's a problem with the uterus contracting and I'm picking up not a whole lot, but yet I've adjusted my monitor pieces and I'm still not picking up a whole lot, but I can feel the belly getting really tight, I may have to call the physician to put one in. Physicians can put them in, and they're the only ones for the IUPC because they are very stiff and can perforate the uterine wall if it coils up in that uterine wall, in that uterus. Somebody that's not a good candidate for this type of monitoring, can anybody tell me? Previous C-section, right. Previous C-section. And somebody will say, well, Ms. Herrera, why are you worried about that? Because a lot of time they go in and have a baby by the same mode. They want to be a repeat C-section. Well, not always. Not a whole lot of doctors do this, but some will let the patient have a trial of labor, especially if it was just that was a big baby and it wasn't going to fit through the pelvis, but this baby's a little smaller. We might be able to deliver you from below. And she may want to do a vaginal delivery. We call that a vaginal birth after a cesarean. You might hear me say VBAC, a VBAC. So if a patient's having a VBAC and needs an IUPC, there won't be one put in because that is already a weakened area of the uterus where they cut through to get that baby out during that C-section. Remember, with a cesarean, they cut through layers of tissue, and they cut through the uterine muscle, and there's layers of the myometrium and all of that to get to that baby in that sac. So wherever that was cut and fooled with, we stitch it back, but it's weakened. It's not as strong. So that monitor piece can coil up and can go right through the wall. Uterine perforation, patient can bleed to death, fetal distress, it's an emergency.
If there's a need for an IUPC and they've already had a C-section, but they want a vaginal birth, would the doctor suggest just do a C-section?
Yeah. If there's no way to monitor, we're running Pitocin and the contractions, again, you know, it's almost like Mother Nature tells you, okay, hey, yeah, it was the baby size maybe last time, but guess what? This woman is just not meant to have a vaginal birth. So if we can't pick up the contractions and we're having to run the Pitocin and we don't know how much we need to be running, and if the baby's having some distress or things are going on, we just may have to do a cesarean. Yeah, she kind of like buys herself another C-section at some point. Remember, it's the best scenario for mom and baby. Even though moms will freak out, oh my God, I got to have a C-section. I'm like, it's okay. Because you know what? I know this is not your dream plan of how you were going to do this today, but it's the safest thing and it's the best scenario for the baby and you. Assessing fetal heart rate tracings. When we talk about decels, we have early decels, we have late decels. So the early ones look like a mirror image, or the lowest part of the deceleration is meeting, or actually prior, and I'll put my math here, so I'm going to go grab a part of the board over here. I'm running out of space. I'm going to go in this corner. So if my contractions are here, here's the peak of the contraction, here's the peak of the decel. And it's almost a mirror image, but it could be slightly prior to that peak. It's early. So if it's occurring prior to the peak or simultaneously like a mirror image, we call it early. Early decels are related to head compression, and that's where the veal chop comes in. Earlies, head compression. Variable decels, cord compression. Acels are okay. We like that. And lates, placental insufficiency, uteroplacental insufficiency. So with earlies, what do we do? What are some interventions you do when a patient's having early decels? What does it mean? We just said that. Head compression. Is that bad? What does that mean? The baby is coming. The birth is coming. So as the nurse, if I see my patient having early decels on the monitor, I'm going to maybe assess her, give her a vag exam and check and see, where's this baby? Is it coming? Because it might be coming really soon. I need to call my physician. Or maybe tell the tech, hey, I need a surgical table set up for a vaginal delivery. I need you to put it right outside my door. Say this baby has meconium stained fluid. I may have to call NICU because they may have to come for this delivery. So I'm going to prepare for my delivery. Okay? So that's early. Late. Of the types of decels, the late are the worst. I don't like these. When I see them, they worry me. They give me gray hair. Late's uteroplacental insufficiency. The uterus and the placenta is not jiving together. They're not on the same page. Something's wrong. And usually, it's a systemic problem, or I call it a pump problem because I think of the heart, I think of the perfusion. So either mom is having some severe hypotension from anesthesia maybe. So what can I do to correct that? I don't like lates, and I always start thinking, do I have a C-section table ready to go? Because if this continues and this baby keeps acting like a little badass, we're going to have a section. So what can I do, though, if it's hypotension that's causing this? Pump with fluids. I can give her oxygen. I can also, if the fluids are not bringing it up fast enough, I can get my nurse anesthetist in a room and give her IV push. What? Vasoconstriction. Not epi, but in the family of epi. It's a vasoconstrictor. I don't know if any of y'all have seen it or given it. Ephedrine. They give it IV push, causes severe vasoconstriction quickly because it's IV, it works quick. All of a sudden, that 70 over 40 blood pressure comes up to 90 over 60, and then it comes up to 110 over 74, whatever. We get it back up. The baby gets that perfusion. Remember, it's not being pumped if the pressure's low. So the blood supply is not going. It's not getting oxygenated. So once we get that done, we take care of it. And we're all good. And then I'm like, okay, well, keep that section just in case, have it ready to go. Because it could be related to something else. If mom's got some kind of hemorrhaging going on internally.
So for the late deceleration, it would be after the peak or in the peak?
It's going to happen after the peak. So if my peak is there, you can see it here. The peak is here. Let me use this because I'm so challenged with these things. Plus holding all this. If my peak is here, the peak here of the lowest part of the decel is occurring after the peak of the contraction. So it's late. It's happening later than the peak of the contraction. The lowest part, or the lowest part where the baby's heart rate is the lowest. So we call it a late deceleration. What can we do? I just kind of told you we can give some ephedrine. We want to pump some fluids. We want to give some oxygen. What about reposition? Reposition, because if mom's laying flat on her back and she has supine hypertension, yes. Okay. Plus, if she's got an epidural causing that hypotension too, because those narcotics going through that epidural catheter can sometimes cause that. They get a preload before the epidural to keep their blood pressure stable because we anticipate it to drop, but sometimes it drops anyway. So Again, we just kind of pump fluids, oxygen. Now, if there's Pitocin going, do I leave the Pitocin on? Do I want to stress this baby any more than it's stressed out? It's already hypoxic. So I'm going to turn the Pitocin off. I may turn it on again once we clear it up and we take care of the problem, but for right now it's going to be off. Variable decels can occur at any moment on the strip. They do not have to be correlated with the contraction pattern. And what are they related to? Feel chop? Chop, chop? Variable, cord, C. So variable is cord compression. That could be baby rolling over its cord. I'm looking at this little segment here, and I'm not a genius, but just from my experience of reading strips, looks like mom's pushing. The contractions on the bottom are zigzaggy. She's holding her breath, and she's pushing down. She's having variables. Now, remember, they don't have to correlate with contractions, but if a baby's got a cord around its neck and it's being squeezed with the contraction, it may compress the cord, right? So I'm thinking this baby has a cord around its neck, a nuchal cord. Because every time she's contracting and pushing, she's having variables. I don't know. Could be wrong. Could be baby just squeezing the cord with contractions and just playing a little game. And sometimes they come out holding on to their placenta, and they look like they're trawling. But anyway, so it could be any of that. It could be just cord. It's related to cord compression. They take on a V or a W or a U shape, and they can occur again at any moment. Baby could just roll over its cord. It could be temporary. It's an abrupt drop and an abrupt return to the baseline usually. Okay, so that's variables. What can we do for those? Reposition, especially if the baby's laying on its umbilical cord. Can we give some oxygen? What kind of oxygen? Am I going to put a little nasal cannula on her? No, we want a face mask. We're going to give, anytime you give oxygen in L&D, it's big buck. It's big stuff. Face mask, 7 to 10 liters. We just don't play around. That other stuff is for child's play. And we just put it on. It's just, I don't know, it's like in your nature. You like oxygen, turn a Pitocin off, turn her over. You know, all these things. Sometimes simultaneously. I'm telling her, roll over if she can. Now, if this is going on and she's not like pushing or anything, of course I'm going to assess my patient. I pull my sheets back and I see the umbilical cord hanging out of vagina. I'm freaking. You hear me? I really am. Because that's not good. All right? That's an emergency cesarean. So when I ask you, what are you going to do? Don't tell me stick the cord back in there. Once it's out, it's out. You can't do that. Now, you can cover it up with some saline gauze, keep it clean, or protect it from getting, you know, any kind of microorganisms, because it is wet, it's moist. But you want to hold the presenting part up off of that umbilical cord. Now, if mom is not at zero station, if she's dilated, but she's not at zero station, baby's head's not engaged at the pelvic, at the ischial spines, right? That's zero station. So there's a lot of room. Can the cord slip down? Especially if she breaks her water and the pressure of the water coming out of the vagina can pull that cord down. That's why we don't let them walk around when they're like not engaged at zero station, because the cord can slip down and then it's compressed. Then it's compressed. And if it's compressed, we have to get the presenting part off the cord. And I've ridden on top of a stretcher under a sheet. They're spreading everything out. I'm in the OR. I'm holding this baby's head up off the cord because mom's got an epidural and she can't feel anything. And I'm holding the head up until they actually cut and get that baby out of that uterus, praying that they don't slice my fingers off. And I've done that at Big Charity all the time. Used to do that all the time. Go to work. Talk about get your adrenaline going. You can't go there with a headache and not feeling good. You got to pull yourself together because you never know what you're going to face. But again, so all these things to do because it's a hypoxic thing going on. It's cord compression. Now, if it's related to the cord just being depressed on the uterine floor, what can I do with that internal monitor that can help keep that cord floating around the baby if she breaks her water and there's no water and there's no fluid around the baby? What can I do? Amnio infusion, remember that? We talked about that. Pumping that saline or that sterile water through that blood warmer and putting it in there to keep that cord buoyant or floating so it doesn't get compressed. We can do that too. All right, let's do another slideshow. Any questions so far? If you understand that one, then you should be a whiz at this one. I'm going to hit you right from the first slide. What kind of D cells are those? What do you see? What are the characteristics that you see that define this type of D cell? Mirror image or mirror image, right? Or here is here. Starting to go down where this arrow is. Do you see? Okay. I notice this is a mirror image here with this one. It's kind of hard to see what's going on back here with this contraction. Well, first of all, you need to find a baseline to know if it's not an A cell and then it's coming down to, because it could look like a D cell if it's coming back down to baseline, but it might just be because there was an A cell. Here's an A cell here. Here's an A cell here. Okay. But these are earlies. So what do we do for earlies? What do you anticipate? A delivery. So what do you want to do? Do you just call the doctor right away? Come on over. Go in the room. Do I want to assess the patient first? I may do a vag exam. Because, you know, you can have head compression go on for a little bit. Not a long time, but it may not be to the baby. I've done that, and the baby's ready to fall out. I'm serious. The head is right there. I could see the baby's head, like without her pushing. So that could be it, or it could be she's got a little bit of pushing to do. But still, I'm going to assess my patient to make sure it is truly the head coming down. And then I'm going to notify the physician and get the tech to set up a table, put it outside, and just get ready. Okay? So these, again, are the most benign. I'm not really worried about these. They don't bother me like the others. But this is earlies. And again, this is on your handout, your outline. It just talks about what earlies are, what they look like, what are some nursing interventions. Performing a vaginal exam to determine the fetus is descending in the pelvis, and if the fetus is not descending, say it's not descending, but it's coming down, but it's kind of stuck. It might be shoulders, kind of wide shoulders. I don't know. But you want to, of course, still notify the physician. Let them know. Baby's, having early D cells. What are these? What's the shape? V's, W's, U's, right? So what is that? Variable D cells. What does it mean? What's happening? Cord compression. And what do I do to eliminate that or help with that? Reposition. Move her to the right or the left side. Give her some oxygen, right? Okay. If there's a cord hanging out the vagina, what do? Saline gauze, and big thing, before you even worry about the saline gauze, you got to get that baby's head off the cord, right? Or the presenting part off the cord, because it's compressing it. It's cutting off its oxygen. Now, if mom has an epidural, she can't do this. You're going to have to do it. Now, I've done a patient that didn't have an epidural yet, and she had a prolapsed cord. We can put them in a position. It's called knee chest, where they can get on all fours in the bed. It's kind of like doggy style. They kind of on all fours. It kind of relieves that presenting part and gets it off that cord. But if a patient has an epidural, she cannot do that. So, of course, we'd have to, But again, you want to make sure that the presenting part is off the cord, because that's what's compressing it. So again, occurs suddenly, doesn't have to correlate with the pattern of labor. They can occur at any time on the strip. It does not have to be with contractions. Well, you're going to stick your hand in there and pull up sometimes. And again, your arm starts shaking because you're holding this big head up, Sometimes it can be crazy. But when that's going on, you're kicking the light or you're pressing the call light. They got a million people in the room with you. And if you can't hold it up long enough, somebody else is going to put a glove on right behind you and go back where you left off. And I'm telling you, it's like gangbusters. Anesthesia's in there because they're dosing up her epidural to get her ready for the section. Because there's two types of epidurals. A vaginal delivery, they're numb to their belly button. But with a C-section, they're numb to the breastbone. So we got to get that level up, because we anticipate, and we're going to bring her in there and get her cut open, and from the time that you call what's going on, y'all would be so freaked out of how fast things happen. From the time we getting that patient in there, that baby is out in 10 minutes. From the time you go in and lift that head up off that cord. It's amazing how fast things happen. They go quick. So we can get that baby, stabilized. Amnio infusion may be used to recreate a cushioning effect on the umbilical cord during contractions that is normally provided by the amniotic fluid. So again, with this cord compression, we can run an amnio infusion. We can reposition her, give her oxygen, vag exam to assess for a prolapsed cord. And of course, you're going to call the physician or have somebody call the physician while you're holding up the head or, whatever's going on. What kind of decel is this? This is last but not least. Those are the worst. Those make me sad. They make me want to cry. They make me panic. If I can't fix the problem. If I can fix the problem, I'm good. We correct that hypertension, we're good. But if I can't and my baby's still calling for help pretty much with those decels, help me, I'm suffocating, okay? I need to come out. Something is not right. I'm not getting oxygen from my mom. So again, what are some nursing interventions? Oxygen. My Pitocin's on, so what can I do with that? Turn it off. What else? Reposition, right? If it's a pump problem and it looks like her blood pressure's dropped, can I give her more fluid? Yes. And if I can't get the blood pressure up, what can I give? Ephedrine. Okay, 7 to 10 liters, face mask, hypertension, increase my IV fluids to get that. Might have to give prescribed medications, that's my ephedrine. Discontinue Pitocin after it's being administered and reporting it to the healthcare provider. Call that doctor. We're having lates. We may even have to, he may say, well, how bad are the lates? Send me the strip. So we copy it, fax it over, document. Document that you sent that doctor, and they're aware of what's going on because they'll come over and say, I had no idea they were looking like that. Nobody told me. I would have come right away. Well, guess what? Don't lie, because I got it documented. It's on the computer, so it happened when it happened, okay? Now, you can go back and chart it after the fact. So, again, documentation is key. All right, and then my last one, this again I'm going to go over kind of briefly. It's just to kind of, again, give you an idea. Y'all definitely want to know how to read these strips. You will have actual strips. You'll have to tell me interventions. It's not going to be tell me what kind of decel this is. It's going to be like, based on this decel that you already know, I'm sure, what are your nursing interventions? Fetal well-being, how well the fetus is doing. Again, we can tell what's going on by the A cells, D cells, variability, baseline heart rate, all that stuff. And then it talks about the baseline. And all this is on your outline. I'm just kind of briefly going over it with y'all, okay? Remember, we're looking at the variability, if it's minimal or absent or moderate or marked. Babies go through sleep patterns. So there might be some very minimal to very null or no reactivity, okay, or variability, notice, because it might be sleeping. You gave mom some Phenergan and some Stadol just to kind of ease the pain so she can get the epidural. You might have a flat line on a baby, but that's expected. Accelerations, again, we look at that. Remember the 15 by 15 rule. 15 beats above the baseline, lasting at least 15 seconds. 2 or more in 20 minutes is considered reactive, or the baby has, that's an acceleration. 15 by 15 is considered an acceleration. And we talked about all those nasty D cells. The earlies. And this again is just reiterated. Lates. And then variables, the U or the V look. Could be a W. Any questions? Really quick, I want to go over a couple of problems of math because you will see those too. And then I'll let y'all go. All right. This test, you're going to see Pitocin problems, okay? You got to know how to figure it out, of how to set your pump in the room. You got to know how to figure out what's going on with the pump in the room and what is the milliunits per minute that the patient's getting. I had worked the math with the last group and I left it up here. But I have a 500 milliliter bag of fluids. I got 30 units of Pitocin in there. Now everybody says, Ms. Herrera, why is it not 1,000? Some patients are fluid restricted, right? They may have chronic hypertension, they may have some cardiac issues, there may be renal problems. So we may not want to overload them with fluid. This way we can make it more potent and less fluid, so they don't need as much fluid to give them the same effect for the Pitocin. So we got 30 units in 500 milliliters. The doctor wants me to start it at 3 milliunits per minute. So when I set it up, my formula is desired over half times my volume. So if I work that out, desired, I want to give 3 milliunits per minute. But it's 30 units in 500, so I got to convert what I have on hand, right? My 30 units, how do I convert? Times 1,000, right? To get 30,000 milliunits. So my 3 over my 30,000 times my fluid, which is 500 over 1, I just put over 1, I get 0.05. But that's not my final answer, right? I have to multiply times, because I need milliunits per minute. And I got to set it on a pump. So if he wants 3 milliunits per minute, I need to set it to milliliters per hour. So I multiply times 60. When I do that, I get 3 milliliters per hour per pump. Y'all see that? So everybody forgets to multiply. So that's, you got to do that last step to get 3 milliliters per hour per pump. Also, another thing y'all need to do when y'all work in math, because I noticed y'all didn't, some of y'all do this. Think logically. If this answer is 1,000 milliliters an hour, you think I'm going to be given that for an induction? I'm going to blow up that uterus, right? So that would not be the right answer. 0.05, can I give that on a pump? No. So you're missing something. Okay, you got to multiply. That's your last step. On the other hand, the physician walks in the room and he sees that the patient's getting 30 milliliters an hour. And he wants to know, how many milliunits a minute do you have going on this Pitocin? So, on that note, this is your formula. What you have on hand over your volume times your desired. Okay? So if I got 10 units in 1,000 for this patient, that's what's hanging. And it's going at 30 milliliters an hour, and my doctor wants me to find out how many milliunits per minute this is. It's going to be 10,000, because I got to convert, over my volume, which is 1,000, times what I have going, my 30 over 1. I come out with 300, because I go ahead and cancel out. I get 300. I need to divide by 60 because I have milliliters an hour, I need to find out how many milliunits per minute. So when I divide by 60, this is my answer. Do you understand that? No. Okay, we'll talk. But when you think about this, you plug in any numbers. If you got this, you could put a million whatever in here. You could put a bunch of stuff in here, and you will come up with the answer if you follow the formula. So you need to know this formula to find out milliunits per minute, and this formula, desired over half times volume, to find out what you're setting milliliters per hour in your room on your patient. That one you will use a lot more than this, but you need to know both because you never know what you're going to find out on the test, right? This is the one you'll use the most, though. And when my students come with me in clinical, they're going to figure this out. They may not be up in the pit, but I'm going to say the nurse is getting ready to turn it up. So what do you think she's going to set the pump at? And you got to work the math. So again, any questions you don't understand, please come see me, email me, make an appointment. You know, I might be in meetings, but we'll work together. I'll find a spot for you, and you can come in and we can go over math. Now the other class told me y'all already had this last week with Miss Quayle. So y'all should be good, right? Yeah? All right.